the likelihood of spread and all those other things which come along with it. So giving importance to assessing patients properly, taking good history, histological subtypes of head and neck cancers. We're going to talk a little bit about how HPE assessment should be done in a certain way to ensure that we don't miss things and we are as comprehensive as possible. We're going to look a little bit at the organs at risk. We're going to look at the base of skull foramens and its contents, some cartilages in the neck. We're going to talk a little bit on the constrictors, neck node levels, spaces in the neck, how we select target lymph node levels in head and neck radiation, and a little bit more on NPC at the end. So I think all of you will be very much aware that this is a humongous, huge topic. I think head and neck radiation can be a 5-day conference and we will still not be able to cover everything. But I hope at the end of the day, it gives us some idea of the importance of certain things in head and neck radiation. So my first slide, which talks about head and neck subsites, because I frankly believe that some may not be very much aware that when we talk about head and neck subsites, and if we are talking of oropharynx versus oral cavity, the relevance of that subsite is the same as saying endometrium and cervix. So I think in certain tumor subsites like gynae and urology, if you say prostate, we say, yeah, prostate. If you say, okay, it's rectum, it's rectum. We think it's a very different entity. But I believe in head and neck cancers, some people may not understand the relevance of why is it so important to identify the subsite of head and neck. So if we say oral cavity, for instance, under oral cavity, we have got all these tumor subsites, which are lip, buccal mucosa, alveolar ridge, retromolar trigon, floor of mouth, hard palate, oral tongue. So the thing about this that I'm just trying to highlight here is that based on the subsite, every single site which arises from it is treated slightly differently. So the contouring may be a little bit different. The target delineation may be a bit different. The organs at risk may be a little bit different. If you're talking about an oropharynx versus an hypopharynx, this is like totally like two different disease entities. It's a bit like talking about vagina versus vulva, where everybody knows that the management is totally different. If you're talking about oropharynx, it's likely tumors which are arising from the base of tongue, the soft palate, the tonsillar pillars and fossa. So I think when we talk about head and neck tumors, when we see the EUA findings, it's extremely important to come up with the conclusion of the epicenter of the tumor and where's the likely origin of the tumor. Is this a base of tongue tumor extending to the soft palate? Is this a soft palate tumor extending to the hypopharynx? Or is this a tonsillar cancer going up into the nasopharynx? Or is it a nasopharyngeal tumor coming down to the oropharynx? So only if we can tell where is the epicenter and what we are dealing with, the whole line of management will actually really depend on that. And having said that, I know sometimes it's not very straightforward, but as much as possible, effort has to be made to find out where is the likely subsite, because based on the primary tumor site, the organs, the extent, the nodes which are going to treat, everything will be different based on that. So if you're talking about laryngeal tumors, you've got supraglottic tumors. Under supraglottis, you've got false cords, arytenoids, epiglottis, epiglottic fold. So I just put this slide up just more to make everyone aware that tumor subsite, that understanding of where tumor subsite we are dealing with is extremely important because everything depends on that. So otherwise, we might end up treating the patient who has CA cervix as a CA endometrium, for instance, which is totally different. When we talk about symptoms of head and neck cancers, I put out this slide mainly to emphasize the importance of asking thorough history as well as looking out for symptoms and signs in patients, which I feel sometimes is neglected and not given the due importance that it should be given. So for instance, if you're talking about a patient with oral cavity cancer, of course, the common things are like non-healing ulcers, but we have an exophytic mass or patch, fine, oral growth. But a patient who has got local pain or referred to the ear pain, does anyone want to answer what does that likely suggest? Anyone? In an oral cavity cancer? Any thoughts? No right or wrong? Anyone can just shut up. Would we be concerned if a patient with an oral cavity cancer has got referred pain to the ear? Anyone? Just feel free. It's a very free and easy session. There's nothing scary about this. You know, we will go about it later. So I just want to highlight the importance of knowing that clinical signs and symptoms are usually correlated with anatomy and pathology as well. So if you're having a patient with neck swelling, fine. In an oropharyngeal tumor, otalgia again, ear pain. So I know sometimes people disregard it by saying, oh, maybe it's earwax or maybe it's you've got effusion or something like that. But you will notice in a lot of these tumor subsites, ear pain is a symptom that you will look out for, just like others. Or dysphagia, trismus. So trismus in an oropharyngeal tumor is very significant of a certain location of the tumor. In a laryngeal cancer or hypopharyngeal cancer, of course, hoarseness is common, especially if your true chords or false chords are involved. But appreciating that there is a change of voice tells you a lot about the possible location of the tumor. Dysphagia probably indicates that the esophagus is likely involved as well, or there's some issues with the swallowing or a swallowing dysfunction, which is likely present as well. Patients who present with stridor, you might want to make sure that your airway is actually fairly patent, or there's no mass effect or any kind of issues with the airway going on at the same time. So quite often we will notice that the EUA findings may be quite brief, or it was done properly, but the information was not transferred to us, and hence we may not realize these things. So when we see the patient, assessing all the symptoms is extremely important and trying to come up with a sensible location of tumor, extent, as well as whether other things need to be done as well. Patients who have got paranasal sinus tumors, maxillary tumors, ethmoidal tumors, sphenoid tumors, patients facing with proptosis, patients presenting with eye signs will warrant us to look in thoroughly to the eye side, the cavity orbit, whether there's tumor extension which is direct, or is it just purely a nerve involvement? Is it a patient with a Horner syndrome where the neck nodes are massive and gross, which is causing a partial ptosis, anhydrosis, whatnot? Patients with, of course, trismus is common in paranasal sinus tumors, most likely due to masticated space involvement. And of course, in nasopharyngeal carcinoma, you can have a whole variety of symptoms coming up. Patients who have neck swelling, epistaxis, neurological symptoms like diplopia, headache, which indicate likely cranial nerve involvement, whether it's a cavernous sinus involvement, whether it's posterior extension into your causing swallowing dysfunction. So it's a whole complex area. So of course, we can't go through every single tumor and every single symptom to look out for, but I hope I can at least pass the message that looking out for signs and symptoms is extremely important. The mind will see what it knows. If the mind doesn't know what to look for, it's likely not going to see what it's looking for or what it should be looking for. So this is just a bit of a summary of what can be potential causes of otalgia. I'm just trying to emphasize here that it can be so many different things affecting many different cranial nerves. Tumors which affect the nose and the sinuses, yes, you can get ear pain. Cranial nerve 10, if you have got an esophageal tumor, can also have referred ear pain. This is all referred ear pain. Cervical spine issue C2, C3, you can have referred ear pain. Tumors in the larynx and the hypopharynx, you can have referred ear pain. Temporomandibular joint dysfunction can also present as ear pain, purely because the cranial nerve pathways associated with otalgia is actually many. So if you've got issues with B2, which is also innervating this area, and you've got a problem in the nasal cavity, you may present with symptoms of ear pain, which is a referred ear pain, rather than a localized problem in the ear. So you will notice that after some time, a lot of patients with head and neck tumors actually have got referred ear pain. So whether it is due to the ear or due to one of these problems. So my question earlier was, why is it that patients with oral cavity tumors may have referred ear pain? Because if you have a tumor in this region here, which affects V3, it may be referred to the ear. Patients who have got base of tongue tumors, cranial nerve 9, referred ear pain is actually very common in base of tongue tumors. Patients who've got jugular foramen involvement may have referred pain as well. Patients with cranial nerve 7. So if you actually look at this picture, it just tells us the complexity of innervation of the ear. So I just used otalgia as one example to tell us the complexity of neuroanatomy in the head and neck region, and the thing about the mind being open to understand that this could be a significant problem, which may be related to the underlying pathology and the anatomy of what's going on. So the auricular temporal nerve, which runs in this region, commonly affected if you have cranial nerves 5 affected, C2, C3 with the angle of jaw, majority of the pinna innervating this area as well. Patients with spine issues, you may have C2, C3 referred pain at the posterior aspect. Patients with branch of the glossopharyngeal nerve, cranial nerve 9, may be seen in patients with tonsillar tumors, pharyngeal tumors, posterior tongue being the most common actually, who also present with referred pain in the ear and branch of the vagus nerve. So I don't think people would memorize all these things, but to be aware that the different cranial nerves in the head and neck region can present with certain symptoms. So this otalgia is just an example of that. You can get that with diplopia, the sign being diplopia, and the multiple different causes that can cause it. You can get this with a sign of ptosis, with multiple different nerves and causes that may actually potentially cause it. So this is another example of cranial nerves as well as signs and symptoms which actually present in the patients. Right superior laryngeal nerve running around here. You've got the right recurrent laryngeal nerve, which is just lateral to the trachea. The left recurrent laryngeal nerve, which very famously goes around the edge of aorta and comes up here. So patients who actually present with hoarseness or even what do you call it, a true cord palsy, right? It can be due to multiple pathologies affecting any of these nerves. So if you have a tumor in your larynx, you will likely also have hoarseness. If you've got mediastinal nodes affecting these nerves, you will likely also present with hoarseness. You may present with stridor as well. But the point that I'm trying to make across here is the complexity of these situations. So based on the location and how the true cords actually sit, paramedian versus intermediate position. Of course, we don't expect people to memorize these things, but to be aware that hoarseness may be just the symptom, but the underlying pathology can be a huge range of things. So in general, if a patient presents with hoarseness, you don't only want to assess the upper airway and the larynx, but you also want to make sure there's nothing going on in the mediastinum, right? Whether it's mediastinal nodes. There are a lot of lung CA patients who have hoarseness of voice. There are a lot of patients with thyroid tumors and thymic tumors who may also present with hoarseness of the voice. When they do an EUA, based on the location and the positioning of the cords, you may have some idea whether this is a problem with the vagus, this is a problem with the inferior laryngeal nerve, or where it's actually it. So of course, we're not ENT surgeons to diagnose these things, but to be aware that when you see the imaging, it has to be correlated with the scope findings, the clinical symptoms, and the radiology that we are looking at. So this slide is purely just to show that when we talk about oral cavity cancer, for instance, it does not only mean one type of cancer. So if the subsite in that particular, no, the particular organ in that particular subsite is going to make a big difference in treatment, the next big factor which makes a difference with regards to how we treat the patient is the histological subtype. So if you're talking about, say, laryngeal tumor or say a supraglottic tumor, and it turns out to be a squamous cell carcinoma, that is may be treated differently compared to perhaps a neuroendocrine carcinoma arising in the supraglottic region. It will be treated differently if it is a gist of the larynx. It will be treated differently if it is a salivary gland tumor in the laryngeal region. If it is an oral cavity or an oropharyngeal tumor, but it's a squamous cell, HPV related, it will be treated differently. If it is an oropharyngeal tumor in the exact same location, but if it is HPV negative, it is going to be treated differently. So the point that I'm just trying to take across is that histology is extremely important. So although we say in the head and neck region, squamous cell carcinoma is the most common, in high volume centers, we definitely see a lot of other things very often. Adenocarcinomas, olfactory neuroblastomas mistaken as nasopharyngeal carcinomas, neuroendocrine tumors reported as olfactory carcinomas, verrucous carcinomas reported as squamous carcinomas, and the whole range will just carry on like that. So the gist of the story is just to say that histology is extremely important. If your histology is coming for a dubious center or you're not quite sure, no proper IC, no proper reporting, very iffy, you would always want to report this because at the end of the squamous cell carcinoma spectrum are potentially curable tumors like rhabdomyosarcomas, which happen in the head and neck region as well. You can get lymphomas in the head and neck region as well. You can get sarcomas in the head and neck region as well. Of course, salivary gland tumors are managed in a whole different way as well. So that's just the point to take home with regards to the importance of anatomy, the importance of clinical science, the importance of histology. When we're talking about histopathological assessment, I think this is an area in not only in head and neck cancer, but in all malignancies in general, where special attention has to be given in reading the histopathology assessment. So the best way to start is to never ever read a HPE based on just the last sentence or the conclusion. Because I know a lot of people actually do that. They actually go to the summary page the first time, the moment they see the HPE. They just look at the summary at the end, conclusion, or squamous cell carcinoma, grade 2, node positive disease, HPV positive, or something like that. So be very, very careful that you do not develop that habit of only reading the last few lines of the summary. As oncologists, pathology is a major subject in year 1 because pathology is extremely important for oncologists. As important as radiology, as important as all other subjects, including radiobiology. So pathology is extremely important. We want to look at the specimen details. Always start off with macroscopy and then go down to microscopy because you will be surprised the amount of information which may be mentioned in the macroscopy or in the microscopy or vice versa. So if we don't read through the whole report, we are likely going to miss a lot of things in the HPE. So anatomical site with laterality. So the head and neck, thankfully, is a symmetrical organ. Being able to compare left and right is a huge benefit because in a lot of times you may not realize there's something going on until you train the eyes to see laterality, meaning symmetry. So left and right, which one is equal, which one is not the same, that actually tells us a lot about potential sites of pathology. incision or excision biopsy. So this is another huge area of concern. If a patient had an excisional biopsy, whether this is an oncological surgery or it is a suboptimal surgery. So the majority of head and neck cancers, especially the squamous cells, are actually cured with surgery. But if the patient's surgery was suboptimal, that patient loses its chance of cure, and it is very rare that anything else will be able to compensate that patient as well as good surgery. So it is extremely important to be sure that before we radiate a patient, if the patient has had surgery, whether the surgery is optimally done. If the surgery is not optimally done, never think twice about discussing with the surgeon again whether optimal surgery is necessary for this patient. So the point to note in our setting in our country is that there are not that many head and neck cancer surgeons. There are not that many head and neck cancer surgeons who have been trained in oncological surgery. So you would be very, very careful wherever you work to be careful that is your surgeon oncologically trained and on the same page as what you are thinking. So if you work in a center, unfortunately, where your surgeon is not on your same page, it's going to be a real nightmare because likely all the patients will get operated and come to you hoping to be salvaged. And trust me, it's almost always impossible. It's very difficult to salvage patients who have poor surgery. So incision or excisional surgery with regards to margins and oncological excision, which was done, the type of surgery and neck dissection. So if I can just spend a little bit of time on the type of surgery. So if we're going to talk about radiating the patient, the gist of the story is not just how we do the radiotherapy, it's the whole spectrum from the initial presentation to the final monitoring of the patients and surveillance after that. So if you have a patient who has got a supraomohyoid versus a selective neck versus a radical neck versus a modified radical neck. So as oncologists, it's extremely important that we are aware what is a selective neck, what is a supraomohyoid, what is a modified radical neck, and what is a radical neck. So if I can just go through very quickly, can anyone just shout out what is a radical neck dissection? What comes out? Anyone? Don't feel shy, it's all masters, we are all trainees, we are all learning. So just quickly, if we go through, we all can go and book up puasa.
Regine here. The radical neck dissection, we take out level 1 until level 5. And also
Plus,
the muscle, the SCM muscle, the
yes,
accessory nerve, and
yes.
internal jugular vein.
Yes. So if I say good. So if I say modified radical neck, all except
One of it.
one of the three does not come out, right? And the three is sternocleidomastoid, IJV, or accessory nerve. So if you took out level 1 to 5 on that side of the neck and you omitted one of those three structures, that is a modified radical neck. If I say selective neck, what does that refer to?
We select the level that we
You
want
can select whatever level that you want. But if I say supraomohyoid, what does that refer to? Anyone?
level 1 until level 3.
Supraomohyoid is only talking about level 1, 2, and 3, usually in oral cavity. So if you did 1, 2, 3, 4, that is not a supraomohyoid. If you did 2, 3, 4, that is not a supraomohyoid. If you only did 2 and 3, that is not a supraomohyoid. So when the surgeon refers, they have to specify what was the nature of surgery, correct? So if they said this is a left supraomohyoid, the next thing to look at in the HPE is whether 1A there are nodes or not, 1B there are nodes or not, 2A there's nodes or not, 2B there's nodes or not, 3 there's nodes or not. So if it's supraomohyoid but no nodes described in the HPE, what is the possible cause for that? Or potential causes or possible causes? Anyone?
The surgeon didn't get the notes.
So maybe they didn't reach that area and they didn't operate, or they operated but they didn't label properly, so miss. Or pathologist didn't get enough notes from this. I couldn't find any lymph nodes for whatever reason. Or sample sudah hilang. Or poor labeling. Or salah patient, salah botol, salah don't know what. Or sudah rosak. So the gist of the story is that we want to know which are those levels which have been operated so that we know whether we need to radiate that area and to what dose we need to radiate that area. So the importance of reading the HPE based on the type of surgery, whether the margins were clear or not, margin involved or not, which area of the margin was actually involved, which nodes were extracapsular positive, which were not involved. So at the end of the day, the summary of the HPE has to involve based on every lymph node level. So if 1A, 0 out of 2, 1B, 0 out of 10, 2, 3 out of 5. So it has to go into that kind of details. It cannot be left neck 3 out of 44, right neck 2 out of 95. Cannot. It has to be level by level dissected, and only then we will know adequate dissection or not, radiotherapy, what dose to give. If it is extracapsular, do you need to push the dose higher to 66 versus just an adjuvant dose of 60? So all these things really depends on the HPE. Any questions so far? If any questions along the way, just feel free to ask or Stop me, yeah? So characteristics of the tumors, margins, level of lymph nodes we spoke about, depth of invasion. So especially in which tumors, depth of invasion is a major problem. Anyone? Tongue cancers, right? In tongue cancers, depth of invasion changes staging. Depth of invasion changes the decision to radiate the neck or not. Depth of invasion makes a big difference in everything. Laterality, crossing midline or not, close to midline or not, already touching midline or not. So if it's already close to midline and it is a subtotal glossectomy and the margin is 1 mm, that already tells you, right? They were trying to skip the margin purely because of cosmetic or function, right? So sometimes there is a recon, sometimes there's no recon, sometimes there's a flap, sometimes there's a recon of the mandible. All these things have to be taken into note because, for instance, if it was a tongue CA and your margin is close at the tongue, and your tumor was saying, for instance, involving the mandible, and the margin they say is close. So is the margin close at the tongue or is the margin close at the mandible which was operated? It makes a big difference, right? With regards to where you would cover and where would you push the dose. If your margin is positive in the mandible, likely your whole CTV has to include the mandible already because your marrow is already questionable. So I'm just trying to highlight here that the HPE is extremely important because based on that, we will decide where is the target for our radiation later. So I hope that everyone takes that message home of the importance of reading HPE thoroughly. Incidence of positive neck nodes based on subsites. So with the complexity of head and neck tumors, multiple subsites, you will notice that majority of these tumors involve level 2 and 3. But in the oral cavity region, you will start to notice level 1 having some importance, which you don't see as much in oropharynx and hypopharynx and laryngeal tumors. Level 4, not as much as well, but in oropharynx, slightly there. When we talk about therapeutic surgeries being done on these patients in a clinical trial setting, again, level 2 and 3. So when we talk about selecting lymph node levels based on subsite, number 1, it depends on the subsite, so the epicenter being important. Number 2, you have to ascertain from this subsite which other adjacent subsite got invaded as well. So if, for instance, you have an oropharyngeal tumor, minimum target lymph node levels would be, anyone? So even if you have a T1 and 0, is minimum level 2, 3, and 4. But if your tumor is a T3 involving the hypopharynx, will the lymph node levels still be 2, 3, 4?
No.
Unlikely, right? So based on the epicenter of that tumor, so we'll see later how every tumor subsite has its minimum lymph node target. And the next question is, which levels on the same side, which levels on the other side, or is it the same for all the midline tumors? So midline tumors in the head and neck will be nasopharynx, hypopharynx, oropharynx, oral cavity tumors which are coming close to midline. So the only tumors which are considered well lateralized would be things like parotid, floor of mouth, alveolar, what do you call it, the alveolus, gingiva, so those which are very well lateralized, buccal, those kind of tumors. Tumors like hypopharynx, oropharynx, nasopharynx, all larynx, all are midline structures, is almost always treating both sides of the neck. Anything in the midline, you're likely going to treat both sides of the neck. So this table is just to show that there's some differences with regards to the likelihood of neck node positivity, and also to be sure that which are those areas that you're going to treat either therapeutically or electively. A little bit about base of skull foramen. So unfortunately, in head and neck radiation, just like all other tumor subsites, without anatomy, I think it's impossible to do radiotherapy. There must be some level of anatomy, some level of radiology, and some level of correlating all this in order to be a radiation oncologist. So when we talk about the base of skull, why is it that the base of skull is actually so important? Is because there are a lot of structures which run within the base of skull. They are not, it's not only nerves. You've also got very important structures like the chiasm, the pituitary, the foramen magnum, the brainstem going in, optic nerve, optic chiasm, whatever you name it and not. And because majority of our head and neck tumors do have some area of involvement of cranial nerves, it is extremely important to note because in a lot of times, the tumor extent and the delineation has to incorporate these areas as well. So of course, the very typical example is adenoid cystic carcinoma with perineural invasion, and you need to chase the nerve until the origin. But although we say that that's what it needs to be done, adenoid cystics are not the most common tumors that we see. The tumors that we commonly see in this country is actually head and neck would be, the most common would be
NPC?
NPCs. And NPCs being NPC, is the tumor with the most number of cranial nerve involvement, right? And base of skull involvement, because these tumors sit smack below the base of skull. And very often there is extension into the base of skull. So even with the presence of MRs and CTs, having some anatomical knowledge is extremely important. So when we talk about these foramens in the base of skull, optic canal, relatively simple, is where the optic tract goes in. You've got the superior orbital fissure over here. Foramen rotundum with cranial V2 runs in. So we always talk about V2 because it's quite a unique nerve with numbness as a presentation when it's affected. Foramen ovale, which is laterally here, where V3 runs in, and then you've got foramen spisosum. So we actually talk about this as a inverted heel sign. It's like a high heel. So of course on CT, if you're doing 3 mm slices, you won't see all these foramens beautifully like this, but you will see most of them. The big ones you will definitely see. Foramen jugular, all definitely you would see over here where the IJV runs in with cranial nerve 8, 9, 10, 11 together with the internal jugular vein, and hence these patients present with gag reflex which is lost or issues with hearing. Foramen spinosum. So these are just the main foramens in the brain. And if we look at the anatomical, the CT correlation on bone setting. So I think these are very, very basic, simple bone imaging, which is, I think, extremely important. Almost all of us are doing CT simulation. I don't think in Malaysia we have MR simulation. So we need to know CT quite well. So CT, parapharyngeal fossa. The parapharyngeal, this is the maxillary, pterygopalatine fossa, sorry, what am I saying? Pterygomaxillary fossa over here, which is between the maxilla and the pterygoid plates over here. So these structures like the pterygoid plates are very, very typical structures in the head and neck region. I know it's complex. It's not possible to know every single bone and every single nerve and every single muscle in the head and neck. But I think it's enough to know the main ones at least, and that will navigate people most of the time and they will know roughly where they are. So things like the clivus, the carotid canal, which are important structures in the head and neck region. If you're looking over here, the foramen ovale, foramen lacerum, which is a huge one, which can usually you can see it very well on all our 3 mm CT simulation imaging. The Vidian canal over here is usually well seen as well. Pterygopalatine fossa between the pterygoids and the maxilla as well, and the palate later on lower down. The carotid canal, where the carotid artery runs through and eventually goes into the cavernous sinus. So these are all rather important structures, which makes a very big difference because in Malaysia, our head and neck load is majority nasopharyngeal carcinoma, where T3, T4 tumors happen almost on a weekly basis, at least for us here in HKL. Every one of us will definitely get a T3, T4 NPC almost every week. So being aware on the proximity of the tumor, where the tumor is potentially going to extend. So for instance, if your patient has already got gross disease in foramen lacerum, you will be very careful to look at the cavernous sinus region in the subsequent slices, as well as the medial cranial fossa, because these are all the areas of least resistance. The tumors are likely going to squeeze through these foramens and eventually appear in the medial cranial fossa. If your tumors are already squeezing out here, within millimeters, they will enter the pterygomaxillary fissure. Your patient will likely have V2 numbness. A few more slices above the tumor will be in the, anyone? Once it's gone into the pterygomaxillary fissure, it's likely going to go a bit more into the orbit. It's likely the next few slices is going to be a superior orbital fissure, and that's when you will have tumors sitting around the optic nerve when your patient comes in with either partial blindness or eye symptoms. So these are all very, very general areas of potential areas of spread, which if we fail to recognize, we may miss it in the delineation. And nowadays in the era of IMRT VMAT, where dose falls off within a few millimeters, the importance of anatomy and correlating with radiology is extremely important, because last time when we used to do 3D, we were very safe most of the time because it's big fields. Likely you won't miss many things. Of course, we fried most of the OARs, but our patients were cured most of the time with some toxicity. But in this day and age, if we miss the area, the patient is likely not going to be cured. And that is, I think, a bigger disaster. So this table basically shows us for all the different cranial nerves, roughly where is the exiting skull. So I like putting up this slide because I think it summarizes to a certain extent. But just to be aware that the different cranial nerves exit through different orbits, different orifices. So if you've got the optic canal is the optic nerve, the cribriform plate is where the olfactory bulb sits, the superior orbital fissure is where oculomotor nerve sits. Superior orbital fissure also has cranial nerve 4, so cranial nerve 3, cranial nerve 4, cranial nerve 6, all run in the superior orbital fissure. So if your nasopharyngeal carcinoma is involving the superior orbital fissure, your patient is likely going to have diplopia because of cranial nerve 3, 6, 3, 4, 6 palsy, and likely the patient is going to have issues with their pupillary reflex as well. Facial nerve in the internal auditory meatus. And of course, we talk about cranial nerve 7, very famous because of its proximity for parotid tumors, right? So tumors in the parotid region, because we know that the nerve runs in between the superficial and the deep lobe. So if you're doing a superficial parotidectomy versus a deep, so total parotidectomy, you likely are going to get a facial nerve palsy. So these are just some important nerves and important things to look out for, which makes a difference in the eventual radiation after that. Of course, the vestibulocochlear nerve in the internal auditory meatus, cranial nerve 9, 10, 11, 12, a lot to do with the jugular foramen, especially 9, 10, 12. So later we will see some images of NPC patients and how when they have posterior extension, especially to the area of the jugular foramen, then a lot of them have impaired gag reflex. So of course, when you talk to the patient, they say, boleh telan, boleh telan, boleh. Ada batuk, tak ada batuk, okay, all very good, all very happy. But the fact is that many of these patients are silent aspirators. Silent aspirators mean, even though they are able to swallow and eat and drink, they appear that they are fine, they are actually micro-aspirating. So these are the patients, even during RT or post-chemo, they will say tercekik, teraspirate, terdemam, tersepsis, termati. So a lot of them will actually succumb because of aspiration. So it's either it's silent aspiration or significant. And so it doesn't mean just because the patient say boleh telan tak ada masalah that they are not aspirating. If their jugular foramen is already affected with tumor, very bulky, majority of them have some silent aspiration. Or once they start the radiotherapy, the mulut is kering, the telan is not so nice, they can't really coordinate their swallowing that well, they may still aspirate during the radiation as well. Usually towards the later parts of radiotherapy, 5th week, 7th week. Some patients will aspirate in the process of all this. So these are actually some things to look out for. A little bit about the cartilages in the neck, why they are important, because when you're doing contouring, the cartilage actually correlates with some surface anatomy. So we know that we've got the epiglottis, we have got the thyroid cartilage, you've got the arytenoids here. So later we'll see a slice for laryngeal carcinoma and how anatomy is extremely important. So for those of you who are planning to sit for exams, please be aware that the cross-section of the larynx comes out very, very often, and asking to label arytenoids, aryepiglottic fold, false chord, true chord, cuneiform, whatever. So please be aware that the table need to be able to identify, because it is extremely important to know these, which is this cross-section, purely because it changes staging. If your tumor is purely confined to the true vocal cords, this is a stage 1 true chord. If your tumor is extending a little bit out from the true cords into the false chord, you're no longer talking about the true glottic. The staging is likely going to change. If your tumor from the true chord is extending a little bit up 0.5 centimeters from the true chord, you're no longer talking about a true chord tumor. You're likely talking about some supraglottic extension. 0.5 centimeters below is already some subglottic extension. If your tumor goes laterally into the paraglottic fat, you're already talking about a T3 tumor. So staging changes, prognosis changes, treatment changes, radiation field changes, everything changes. So if you've got a T1N0 true glottic RT and surgery equivalent, the moment you're talking about T3, we are no longer talking about surgery equivalent to RT anymore, and hence the importance of knowing this well. So this is a graphic drawing, and this is actually a picture which you see from a scope. So how you would see the true chord here, the false chords on above, the aryepiglottic fold, the epiglottis. Number 6 is the piriform sinus, which is the hypopharynx. So when you've got hypopharyngeal tumors, how direct extension into the larynx is a T4 tumor. So all this needs at least some basic anatomy, some basic labeling, some basic features like this must be known. Otherwise, when we see the report of the EUA or the biopsy, like cannot make out anything out of it. Like don't know where or what we are even talking about. So just in brief, all these cartilages which arise in the laryngeal region, the epiglottis. So this structure, which is an extremely important structure in the neck. Anyone? This is the
Hyoid bone.
hyoid. I need to ask because I don't know whether I'm talking to myself or when to book up for something after later. So anyway, the hyoid. The hyoid is an extremely important structure. Why? Because it's a bone. It usually correlates to which level? Cervical. C? Roughly C3, C4, right? In most human beings. And the lower border of the hyoid is the start of level?
Level 3.
3. So lower border. So if you're drawing contouring, you start to see lower border of hyoid. You know you have already finished level 2 above, as long as you're posterior to sternocleidomastoid. So lower border of hyoid until the lower border of cricoid is level 3, right?
Level 3.
3, and after that is level 4, lower border of cricoid, light down up to 2 centimeters above sternoclavicular junction. So later I would like to emphasize that when we are drawing neck notes, I know for many who are new to contouring in the neck region, It can be a very daunting experience. We've all gone through that phase of like a nightmare like that, trying to draw head and neck contouring. But the only way to learn it is to practice. So to have the atlas side by side while you're drawing, nowadays there are so many interactive online or what. Our time last time got nothing one. Just have to buka the buku besar-besar, page by page, scroll, read, draw, and then read. Last time no online, no soft material, soft copy, nothing. Nowadays with the online versions, I think it's so much easier. You can actually put two screens side by side, draw here, see there, draw here, see there, also you can do already. So the only way to learn techno contouring is to be aware of some basic anatomy. So structures in the head and neck region, which are important to look at when you're drawing, are the mastoid process, C1, hyoid, thyroid cartilage, cricoid, clavicle, sternocleidomastoid. So if you see these 6 structures, you roughly know whether which level you are at. If you're at the lower border of C1 up to hyoid, you're at level 2. If you're posterior to the sternocleidomastoid, if you see the submandibular gland, you're in 1B, and anterior to that, you're 1A. If you're posterior to the sternocleidomastoid and you're still at the region of between hyoid and cricoid is level 5. So I'm just trying to say that if you know these main 6 to 7 structures, you will likely know how to draw the neck in general. Of course, not in detail, but in general, which is, I think, fairly good already to start off. So you already know whether this is 5, this is 4, this is 3, this is 2, this is 1. When you know all that, later you can find out where is 5A, where is 5B, where is 4A, where is 4B, where is 6A, where is 6B. You know, it just carries on like that. But at the point of starting as trainees, it is important to at least have that gist of knowledge before you can actually proceed further from there. This is, I think, a very nice picture to tell us the anatomy of the laryngeal region so that we are aware that the false chord is like an indentation of the mucosa which comes in. So when we are looking with the scope from the top, right, the true chord is here and the false chord appears like an indentation on the top, but it's actually just a mucosal folding, and that's why it's called the false chord and not the true chord. The true chord is like 2 wires at the middle in this region. So why this picture is important? Again, because the staging is different and how you would treat it is actually different based on whether the tumor arises in the false chord. So for instance, if your tumor arises in the false chord, what subside is this? Anyone? Anyone? False chord would be which subside in the head and neck region?
Supraglottic.
Supraglottic. So it is no longer a glottic tumor. This is a supraglottic tumor, right? Whereby the target lymph node levels is no more like a glottic. It is likely retropharyngeal, level 2, level 3, level 4. All this has to get in your target. So the point I'm trying to make here is that based on the epicenter and the extent, the target for the primary and the lymph nodes has to be decided. So it's like a prescription. If you think, okay, this patient is larynx, what stage, what is the extent, which lymph node, then you plan in your head already. Okay, I'm going to treat primary, margin, area of extension, high-risk subclinical disease, and this lymph node levels as my target. So that's just the summary of it, because we can't be going through every single tumor subsite, but to consolidate the thinking in that manner would, I think, be very, very helpful. So we saw this earlier about the larynx. I put this slide up just to show a little bit for those who may not be very aware of the importance of the constrictors in the head and neck region. So although we can control the constrictors, you can control the brachial plexus, you can control the temporomandibular junction, you can control the temporal lobes. I wouldn't say that everybody does it as a routine, but to be aware of this location of these constrictors. So you will notice that the constrictors, there's the superior constrictors. It's like pairs of muscles which line all along the posterior aspect of the pharynx. So it's like a U-like structure which goes at the back and it spans all the way from the, anyone? This structure would be where, from where to where? Anyone? This starts at the base of skull. The constrictors start at the base of skull and comes right down until the level of cricoid. So this is hyoid, this is thyroid cartilage, and this is cricoid. So the superior constrictors, the middle constrictors, and inferior constrictors. So the point that I'm trying to make here is that when we do contouring in the midline, to be aware that the constrictors sit along this area, and the constrictors are volume-based or Dmax-based, anyone? The tolerance is volume-based or Dmax? You try not to exceed maximum dose, or you have to be wary of volume? Volume, right? So it's volume-based. So the more and more you draw at the midline, the tumors coming more and more in the midline, to be aware that how much of the constrictors you're likely getting into the radiation field makes a difference with regards to if the patient survives radiation and lives to see no recurrence, whether swallowing dysfunction is going to be a problem in the long term. So in the era of 3D and 2D, I think we did see quite a good number of patients with swallowing dysfunction. So in the last times when we used to do 2D radiation, majority of our patients had constrictors getting up to 70 Grays. It was what we used to do, and that's how it was treated. A lot of patients were cured actually, but after some years, we of course saw patients who came with pec tubes and NGs. So the constrictors in the midline structures, right? So in this region, so the superior, middle, and the inferior constrictors. So these are just some examples of tables showing how the tolerances of the constrictors are associated with being PEC dependent, risk of aspiration, strictures. So in general, you will notice in all these trials in general, these are rather old papers actually, but you will see a range of 40 grays, 54 grays, 40 to 50 grays. So in general, a lot of us when we contour, we try to keep the midline as much as possible left than 45 grays. So in the midline, in the head and neck region, there's rather important structures. Yes, the constrictors. So it's a volume-based structure. So of course, you cannot omit the constrictor completely, but as much as possible in the midline, if you restrain your dose to less than 45 grays, hopefully you will save the patient some element of not only swallowing dysfunction, esophagitis, mucositis in the midline, throat discomfort, some element of the xerostomia as well. So we'll see later how in the contouring, we will always draw the structure called the P structure, the oral cavity and larynx, and try to bring down the dose less than 40-45 if possible. So we spoke about anatomy, the base of skull, some nerves and all this. So I think doing head and neck radiation without addressing this is, I think, quite impossible. There are spaces in the head and neck region which are important because the pattern of spread of disease very often follows this. So if you've got the masticator space lateral here, which involves the, anyone, what muscle is this? Very important muscle lateral to the rami of the mandible. Masseter muscles, the pterygoid, right? Lateral and medial pterygoids here. Lateral pterygoid here, medial pterygoid here. So any tumor, especially our most common tumor, which is NPCs, very often extend laterally. When they enter the masticator space to infiltrate the pterygoid, either the muscles or these pterygoid muscles are huge muscles, you know, they hold the whole jaw and the xyloid. So these muscles, when they get affected, the patients will present with trismus, can't open the mouth because the pterygoids are the muscles which controls our mastication, right? To open and close the jaw. So when you've got tumor infiltration into the masticator space over here, majority of patients will have trismus or limited opening of the mouth, can't open completely. So this is the masticator space, which is a very important space in head and neck tumors. A lot of paranasal sinus tumors have masticator space involvement. NPC, no need to ask, very common. Some oral cavity tumors. Maxillary tumors which extend laterally, orbital tumors which extend inferiorly, upper gingiva tumors which go superiorly. A lot of this will have masticator space involvement. The pharyngeal mucosal space, which is nasopharynx on the top, eventually oropharynx, later hypopharynx, later cervical esophagus, later thoracic esophagus. So this is a continuous space which I can show you all here. So the nasopharyngeal region, posterior to the nasal cavity, the same area of the pharynx will become the oropharynx, posterior to the oral cavity. Once you start hitting C3, which is where your hyoid is, posterior to the hyoid to the cricoid is your hypopharynx. Once you pass the cricoid, the hypopharynx will eventually become the... Anyone?
Cervical esophagus.
Cervical esophagus. When you enter the thoracic inlet, your cervical esophagus is now the
Upper thoracic esophagus.
upper thoracic esophagus. So basically, it's all in continuity. Nasopharynx, oropharynx, hypopharynx, cervical esophagus, upper thoracic esophagus. So just to be mindful of these spaces and how they are in relation in the head and neck region. Pre-styloid parapharyngeal space. So the styloid process is an extremely important structure in nasopharyngeal carcinoma contouring, especially. Later, I'll show a little bit. So the pre-styloid space versus the post-styloid space. You can't see it. So this is your styloid process. It looks like a stillet of an iPad. It's like a long bone that comes sharp like that. So when we see the imaging later, I'll show you all the styloid process. So in nasopharyngeal carcinoma, the post-styloid space is in the high-risk CTV, and hence, when we draw, the post-styloid space has to get into the high-risk CTV contouring. Retropharyngeal space, an extremely important space in the head and neck region. It's a potential space anterior to the prevertebral muscles. It spans all the way from where to where? Anyone? Maybe this table gives answer. The retropharyngeal space starts at the
Base of skull.
base of skull, the yellow space, right? So this yellow space, which is a potential space running in front of the prevertebral muscle, starts at base of skull, which is now in the most recent Vincent Gregor Atlas. This is level. Anyone?
This is
Base of skull up here is level.
this is the lymph node level, is it?
Retropharyngeal. 7A,
Level
right?
7.
7A.
Yeah, when we learned oncology, there was no 7A.
Yes.
Now it's 7A. So this is 7A. and the retropharyngeal, right? So it spans anterior to the prevertebral muscle and it comes down all the way until level of
higher.
almost higher and even a bit lower sometimes. So this potential retropharyngeal space is extremely important because there are lymph nodes which can arise in this region, and very commonly it is the retropharyngeal. So retropharyngeal also got medial and got lateral retropharyngeal nodes. So when we do head and neck contouring, extremely important to look out for these areas. So look for the vein, look for the artery, and look for this space here, which is where the retropharyngeal nodes usually appear. Very, very common in nasopharyngeal carcinoma, hypopharyngeal carcinoma. What other carcinoma? Anyone? You must look for it. Even if it's not involved, you need to include it in your high-risk CTV.
Hypopharynx.
Hypopharynx, nasopharynx, supraglottic tumors, right, in general. So all this area here, which is the retropharyngeal space, must be looked for lymph nodes. If it is not involved, at least prophylactic dose has to cover the retropharyngeal space. Carotid space. So carotid space is around the carotid artery, where sometimes you can have lymph nodes as well. So level 2 of the neck, when it goes superiorly, it becomes the post-thyroid and the retropharyngeal space. Once you come below a level of C1, this is going to be level 2, right? The lymph node levels around the carotid vessels. You've got the posterior cervical space, and of course, you've got the parotid space as well, which includes the superficial lobe and the deep lobe. So these are just very, very basic anatomy. Some important structures in the head and neck, without which I think is very difficult to do radiotherapy. You can see here the styloid process, and this being the parapharyngeal space, the pre and the post-styloid space. So when we do NPC contouring, this area posterior to the styloid, posterior to the styloid, around the jugular foramen, all this has to get in. Not jugular foramen, sorry, carotid space as well. So this is the retropharyngeal. The green is the carotid space. The orange is the parotid space. And this is your masticated space. This is a slice in the oropharynx, so it's a bit lower down. But just to emphasize that the eye must be trained to see in spaces. In the head and neck region, it's complex, but if you simplify it into spaces, it's very much easier. Otherwise, when you see imaging, it's going to be very confusing and you'll be all over the place. So a little bit here on CT, since we are doing a lot of MR and CT-based voluming. So just to show the masticated space, this is the rami of the mandible, the bone, right? The bone is black. This is the masseter muscle. This is the medial pterygoids, and this is your lateral. So if you see it from coronal, this is lateral pterygoid. LPP is pterygoid, so lateral pterygoid. This is your temporalis muscle, lateral to it. This is the rami of the mandible. This is your masseter. And this is the medial pterygoid. This is a huge muscle which attaches to the base of skull coming down to the rami of the mandible. So this is tumor. So if you have tumors over here going laterally, your masticated space is affected. A lot of these patients can't open their mouth. Another important structure in the head and neck is the parapharyngeal space. You've got the parapharyngeal space is a diamond-like shaped space with the base of the pyramid at the top. Not diamond, sorry, pyramid. So at the base of skull is where the parapharyngeal space starts. So when you're doing NPC radiation, you will realize that the parapharyngeal fat, right, starts at the top, at the base, at the nasopharyngeal region, and it narrows down all the way to the bottom. Later, when I show you all some CT images, I'll show you all how the parapharyngeal space comes all the way down right to the level of the hyoid. So along the way of the parapharyngeal space, you will see the tonsil medially, you will see the parotid laterally, you will see the pterygoids laterally in some point. At some point, your soft palate will be medial to the parapharyngeal space. So when you read radiology reports or you see imaging, you will realize that this parapharyngeal space is going all the way to the bottom. So when you've got tonsillar tumors, there can be a parapharyngeal involvement. When you've got a hypopharyngeal tumor, you can have parapharyngeal involvement. When you've got a laryngeal tumor, also you might get some parapharyngeal involvement because this structure spans all the way from the base of skull right down to the hyoid. So I think these were some areas that as trainees also, we never really realized. But as we went along, we kind of figured it out. So I thought it was quite nice to put it up just to highlight these things that I think some of us kind of figured out after some time, after a very long time. So, oh, the parapharyngeal space comes down like that. No wonder you always have the parapharyngeal space coming all the way down along the base of skull, right down to the hyoid. So you will notice that the relation of it makes a difference with regards to the extent of tumor and how it is delineated. Just to highlight a little bit, again, all these spaces will have some contents. So the thing about spaces is that some are fat-filled, some are air, some are water, some are potential spaces. So for instance, the cavernous sinus is a potential space. The retropharyngeal space is a potential space. The parapharyngeal space is fat. The pre-styloid space has some vessels, has some nerves, has some others. But just to highlight that a lot of these spaces have structures running within and you've got your nerves running all over the place. It's not necessary to know exactly where every single nerve is running, but to be aware that in certain tumors, like if you've got a parotid tumor, look out for cranial nerve 7. If you've got a base of tongue tumor, look out for cranial nerve 9. If you've got a nasopharyngeal tumor, look out for every single nerve. And you've got other tumors, which are those important nerves that will make a difference. Any questions so far? Or if it's too fast, please let me know. We're trying to rush for buka puasa. Cik. Aku pula. Any questions? If there's questions, please let me know.
Sorry,
Yeah.
Dr. Vash. I'm just
Yeah.
wondering for our for the lymph nodes, because I forgot to ask just now. If for surgeons to do a lymph node dissection, are there any a minimum lymph nodes that we are actually that's considered adequate?
Yes. So just like how for us, if we say it is a particular subsite, these are minimum target lymph node levels. That also applies to the surgeons. So for the surgeon, for instance, if you're talking about a T3N0 or T3N1 larynx based on imaging, right? So when they discuss in the MDT about the nature of surgery, they're going to go through the radiology in detail. They're going to go through the EUA in detail, and they have to decide what is the nature of surgery that needs to be done. So of course, the primary is one problem. How is the approach going to be? How extensive? Is it partial laryngeal versus total laryngeal? Total laryngeal with hypopharyngeal versus esophageal with partial pull-up? Or is it just a simple laryngeal? Total, all the kind of things will be discussed for the primary. And the next thing that they need to discuss is the lymph node level. So they also have got their basic lymph node levels which need to be operated, which is very similar to what we saw here. So this is MSKCC. So I just put it as a rough table. It's not the absolute Bible, but just to highlight that which lymph node levels will be operated is the same like what lymph node levels we are likely going to radiate, right? So at the end of the day, we know that for a hypopharynx, okay, which are those lymph node levels that are potentially at risk for an oropharynx? And that is how, based on the multiple studies and series that has been there, is how they come up with the with recommendations like this. So if you look at this clinical paper, Vincent Gregoi's target organ lymph nodes, right? Where is it? Lymph node delineation. All these papers, right, which have come up. So whether you follow Gregoi's, which was in 2003, it was updated later. And the most recent one that we have is the 2014 delineation of neck node levels. Is if you read at the paper, right, it's all based on all the multiple series of all the different head and neck teams in the whole world. So major head and neck teams that exist in the world are the group from MSKCC, the Denmark group. Then you've got the group from China, the Sun Yat-sen group. Then you've got also, of course, Singapore, which is contributing quite a bit, especially when it's nasopharyngeal carcinoma. And then you've got the Australian group. Then you've got the Franza group, which is Australia, New Zealand. So when you look at all these clinical papers, the first whole perengan, right, of the clinical paper, so I put up for this one, which is the target organ delineation. Where is it? So if you look at all these people, right, Vincent Gregor, blah, 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 some of you may recognize some of these names. I think the famous ones who have come to Malaysia include Dr. Sarbani, Dr. Tejpal, who are from Tata Memorial, India. You have got Anne Lee, who is from Hong Kong. You have got Sandra Posidu, who is from Australia. You've got Dr. Joseph Wee, who is, of course, very famous from Singapore. You've got Dr. Craig Rao, who is from Denmark. So these are all a multinational consensus with regards to how they feel that the title delineation has to come out. So it's based on all the data that they've got from all their series. Among their patients, how many patients with hypopharynx T2N0 had level 2 and 3? How many patients at T1, T2? So this is an international consensus. And even if you look at the title of this, right, delineation of primary tumor, blah, 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 the IRO is a particular group. So all those countries that I mentioned to you belong to one of these groups. The HANCA is the Denmark group. URTC is the European group. GORTEC is, I think, German. HKN is the Hong Kong group. And then you've got all these other, the TROC consensus guidelines. So it's basically a summary of what all the experts in this field believe is an acceptable way of delineating patients. So to answer your question, yes, there is a target and there is a defined target organ, target lymph node levels which must be operated upon.
How about like minimum number of nodes? Is there such
So there are
thing?
recommendations with regards to minimum number of nodes, although I'm not a very staunch believer of minimum number of nodes because I personally believe it is very subjective to too many things. The surgeon, the pathologist, the person who crosses it, the person who stores it, the person who removes the nodes and frozen sections it. So there's multiple factors to it. So yes, you've got a minimum number of nodes. I don't know what's the actual minimum number of nodes, which is the gold standard. But yes, we know that every level has to be represented as much as possible. Of course, more is better. So just like pelvic lymph node dissection, you would see some surgeons having 40 nodes from the left and 30 nodes from the right. And we have also seen surgeons who get 100 nodes from the left and another 100 nodes from the right. So does it mean that the 100 node surgeon is a better surgeon? I don't know. I have no idea. But I think a minimum number of nodes is required. If you ask me what's the minimum number for head and neck, I don't know. Because I think there's too much variability in that. As long as the node is the level is dissected, the nodes are adequate, I think it's good. What is adequate? I don't know. If you know, let me know. Any other questions? Okay, so we're going to talk about OAR contouring. So if we're going to talk about organ at risk contouring in the head and neck region, I think it's, like I mentioned, it's one of the most complex areas. But I think, frankly, in my personal opinion, the only other subside that is maybe more complex or horrible is I think it's upper GI. That's a very complex area to radiate as well. But other than that, I mean, head and neck almost always stands as the champion. But I think it's interesting. I mean, after a while, yeah, it's challenging. I think even after many years, most people are a bit scared of head and neck in a certain way because of its complexity, but I think can be done and hopefully we don't miss too much. So anyway, so basically just to highlight here that if you go into the guidelines, I think previously when we did some of the teaching, we shared all the guidelines for OAR, for delineation, for PTV, blah, blah, blah. But in general, we would know that there are some boundaries. I don't think anyone can memorize what is the medial border of the submandibular gland and what is the lateral border and what is the superior border. I think for many of us, it is just draw, check with the atlas and make sure it's accurate. Of course, you can memorize, you're very free and you have a lot of memory power, but I think it's not that practically doable for most people. But to be aware how it's supposed to be done and to check once you've drawn it, that, okay, this follows the atlas and this is based on the recommendations. So if you draw and you check with the table and you say, yes, it's correct, after a while, you know that it's correct and you just do it that way. So to maintain the margins, to maintain the borders, and that would be it. So in general, when we talk about head and neck, there's at least about teens, I think 17 or 18 minimum OARs that need to be contoured. Of course, you can do more advanced level OAR contouring like brachial plexus, constrictors. You can do a temporal joint, temporal lobe, blah, blah, blah. But at the end of the day, if you draw it, you need to maintain the constraints and then we get good outcomes. Drawing it but not respecting the tolerance may not make much of a difference. So for instance, this one, the constrictors, you will notice it's like this U-like structure which spans all the way from the base of skull right down to the hyoid or even lower sometimes. So at the end of the day, I think it's a clinical judgment. Of course, if you follow the guidelines, you should be drawing all these structures. But I think in general, in all practicality, I think most people tend to omit some structures, but they would be mindful when they're drawing where they're going. So for instance, if I have a big neck node in the region which is below C5, I would be a bit careful about the brachial plexus. So even if I don't end up drawing the brachial plexus, I will make sure I know where are my scalenes, where is my tumor, where is the dose roughly falling in that region, and I'll make a clinical judgment of whether this is likely going to exceed my brachial plexus. But of course, ideally, it is delineated and looked at in a very objective manner. So just like that, brachial plexus in this region, in between the scalene muscles, there's a whole atlas on how you draw all these things. But I think in all practicality, the basic structures need to be done properly, and hopefully then we will get good tolerances which are achieved. So I showed this just now, delineation of primary tumor clinical target volume in larynx, hypopharynx, oropharynx. So the point to note in head and neck cancers is that NPC stands alone as a separate disease entity. Most of the other tumors are lumped together as larynx, hypopharynx, oropharynx, and oral cavity. So in general, the guidelines for NPC is the one which is in a tangent and it sits on its own. Later, we will see how the guidelines for NPC is so varied. I think you all might be aware that Professor Melvin Chua's team is coming up with some kind of a consensus with regards to post-neoadjuvant therapy contouring, which I think should be coming out end of this year or early next year. So I think there's a large areas of uncertainty, but within that uncertainty, I think we have got some guidelines with regards to how we draw, and no two people will draw the same, but in general, if we follow the principles, I think most people are good to go. So CTV delineation in non-NPC head and neck cancer. So we know that GTV primary. So for those of you who are new, GTV refers to gross tumor volume. Primary meaning P primary. Delineation from clinical and imaging assessment. So of course, if you're talking about the era of neoadjuvant therapy, NPCs, we do a lot of neoadjuvant. If we go to the non-NPCs, the role of neoadjuvant becomes a bit debatable. But nevertheless, the concept is that if you have given your patient whatever prior to that, prior to radiation, had chemo, had targeted therapy, had surgery, had whatever, GTV in concept is what you see during the simulation. So it does not take into account what therapy or what has happened to the patient prior to that. So strictly speaking, GTV is what's seen at the time of sim. correlating with the patient's clinical and imaging assessment. So fusion with MR, fusion with CT, fusion with PET, all that helps us get a bit more certainty with regards to the extent of the tumor with GTV primary, CTV primary 1, CTV primary 2. So CTV primary is usually a 5 millimeter margin. So this one we are talking about non-NPC here, not to be confused with NPC for those of you who are new. So NPC is a whole different disease on its own and the whole different contouring, blah, blah, blah. Non-NPC would be referring to hypopharynx, oropharynx, oral cavity, larynx, those kind of things. So CTV1, which corresponds to the GTV primary plus a 5 millimeter margin, which can be edited for air, bony boundaries, which you feel that the tumor is not likely going to cross those anatomical boundaries. And from there, a CTV2, which is usually another 5 millimeter margin from there. So having said that, there can be some variations with regards to how people do this, because all these guidelines are based on the clinical assumption that CT available, MR available, no long waiting time, treatment ASAP, onboard imaging, at least CBCT for MRT VMAT, that kind of a setting. So if we don't fall into that setting, I think that's where the clinical judgment has to come in based on where you work. So if you work in a center which is 100% privileged, everything available at the doorstep at your disposal, I think all these guidelines are excellent, and this is what is to be mentioned in exams. But nevertheless, in all other practicality and with all the uncertainties that go on, correlating the patient based on their history, scope findings, surgery, blah, 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 like we mentioned. So most of you would be aware, at least in Ministry of Health hospitals, most patients' imaging investigations may have been 1 or 2 months prior to that you actually see them. So to be really strict on what is found in the scans may not be relevant if the patient was seen 1 or 2 months ago, and now only we're going to do the radiotherapy, and the radiotherapy will start 3 to 4 weeks from now, if you're lucky, and you don't know what uncertainty furthermore is going to happen. So that clinical judgment of 5 mm plus 5 mm stands, yes, but you may need to take other things into consideration as well, depending on where you work and the uncertainties which are numerous in our setting in all its reality. So anyway, correlating history, scope findings, nature of surgery, histopathology, the primary site of the tumor, the pattern of spread, adjacent sites that are involved, target lymph node levels, region at higher risk of microscopic disease. So the reason I put all this up is because in all reality, in the high-risk CTV, right, the CTV1, I think a lot of us tend to include all these areas into our primary tumor. So although it says 5 millimeter margin, yes, 5 millimeter margin, theoretically it's 5 millimeter margin, provided you have an MRI, you're absolutely certain that this is my GTV and this is going to be my CTV, which is 5 mm margin. I think sometimes the clinical judgment has to be given some level of emphasis as well. So regions of microscopic. So anyway, so if you have a base of tongue tumor, so this is all from the guidelines. I just showed you that because maybe some of you all have not seen it before. So if you've got the red area, which is the gross tumor, so this gross tumor has correlated with the MR, or if you have a PET, great. If you have got some clinical findings to correlate it with, it's basically what you see at the time of SIM. The CTV1, you basically grow a 5 millimeter margin and you crop off air and bone, which you can do. And the CTV2, sorry, is another 5 millimeter margin around that. So if your area of the tumor is here, this is the area of region, provided that uncertainty is minimized. So as much as possible, the guideline that came out from this consensus is a lot to do with margin. So growing from the primary tumor. So this applies for a base of tongue SCC. If you've got a tonsillar tumor, so tumors in this region of the tonsil, I think clinical findings must be correlated very, very well as well, because although CT and MRs are great, quite often for mucosal lesions, it is what the eye sees that might be more relevant, right? So CT and MR may not pick up something like this, which is very obvious on the on inspection, which may not be as obvious on the CT or the MRI. So the end of the day is correlating. So your primary tumor is red, your 5 millimeter margin around it, cropping off air, cropping off bone, cropping off anatomical and muscle. If you see this area of muscle over here, to show that they have actually cropped it in. So it's not really 5 centimeters and overlapping into the area of the pterygoids. It is actually cropped off because this is not a anatomical, this is an anatomical boundary actually, where you don't have the tumor crossing over into the other side. And the CTV2 after that, which is a 5 millimeter margin from there, and allowing you to crop again. So this is an example of a laryngeal SCC. So gross tumor again. In a lot of head and neck mucosal lesions, the EUA findings might be the gold standard of what you have. It may not be the CT, it may not be the MRI. And hence a lot of importance has to be given to the EUA findings, which I think very often we don't get that kind of information. But taking some effort to get that information may make a very big difference, things which may have been missed by the radiologists. So for the radiologists, if they didn't know what was seen on EUA, they're just going to report on basis on what is seen on the imaging. And we know that in head and neck mucosal regions, the EUA is superior, provided done by a good person who is doing the score, who reports properly, writes in detail, pays attention to detail, and that's where you will get a difference, because quite often the EUA may upstage the patient. So, and we may miss those areas which we thought was not involved. So primary tumor GTV, CTV 0.5 centimeters, cropping off bone, cropping off air, PTV, CTV2, another 5 millimeters cropping off again, and then taking it to the PTV. So this is an example of a hypopharyngeal carcinoma. So this is a large tumor in the piriform sinus. So in the piriform sinus, again, the GTV, so it's margin, cropping off anatomical landmark, anatomical boundaries, CTV2, after that another 5 millimeter margin. So in these guidelines, they would actually go into many different examples of different tumor subsites. But in general, for larynx, these are radical radiation and not post-op radiation. So this is radical radiation. Post-op radiation is a bit different. So anyway, radical radiation for primary gross tumor intact. Posterior pharyngeal wall SCCs, of course, MRIs make a big difference with the submucosal involvement, direct tumor extension. So if you see this on EUA, you see this on CT, for the MRI, you might likely see a lot more, which will make you get bigger margins in. So you can actually crop off air in the CTV2, CTV1, cropping off air, cropping off bone, cropping off anatomical boundaries, and the CTV2 margin from there. Any questions so far? PTV is institutional. I didn't talk about notes. We're going to talk about notes after this. PTV would be a margin around the CTV 2.5. So like I always mention, PTV margin is institutional. So HKL is 5 mm. So if whether your center is 5 mm or 3 mm or whatever mm, you need to find out from your institution, because the PTV margin comes up, is brought around by the physicists when they do their initial QA studies and verification and blah, blah, blah. So you need to find out, if you move to a new center, what is the PTV margin in your center? And the PTV cannot be changed for any reason. By right, the PTV should just be a margin around your CTV, because it's taking into account setup inaccuracies, whatnot. I think it is only in prostate cancer where it is allowed to crop the PTV. In all other settings, majority of the time, the PTV is an isometric expansion of the CTV. Any questions so far?
No.
Okay, so adjuvant post-operative, we'll talk about the neck later, but post-operative radiation. So we know that in general, post-operative radiation is given for large tumors in general, T3, T4. It may not be the same for every tumor subset. So the other day when I met some of the trainees also, I was telling them the importance of summarizing the brain. Summarizing the brain means summarizing the tumor sites and summarizing it in a way that if I tell you T3N1 larynx, what are you going to treat? Or what is the option of treatment here? If it's T2N1 buccal, what is the options of treatment here, and what are we going to treat the patient? So for those especially who are already preparing for part 2, it is extremely important to compartmentalize the brain. So meaning one summary paper at the end, for instance, if it's oropharynx, if you're talking about oropharynx, you're talking about tonsil, soft palate, posterior pharyngeal wall. Tonsil T1 N0, options of treatment. If it's going to be radiotherapy, is it 3D? Is it IMRT VMAT? How am I going to scan the patient? What is the slice thickness? Is it contrasted? Where's the hand? What's the neck position? I think for some of you, I might sound like I'm repetitious, but more for the benefit of those who have not heard it before. It is extremely important for the mind or the brain to be summarized in that way, because I think most people know what they want to do, but they can't get it out in an instantaneous manner because they've not thought of it in that way. So if I tell you a T3N1 buccal, how are you going to treat this patient? So you decide, okay, surgery versus followed by post-operative radiotherapy. And then they tell you the next sentence is, patient is not fit for surgery. How are you going to do the radiotherapy? So then they will come this question of, is it one-sided, two-sided, one side of the neck, both sides of the neck? If it is the neck, is it 1, 2, 3, 4, 5 level? Or is it 1, 2, 3, 4? Is it 1, 2, 3? So all this, the brain has to be trained to think in that way. So the only way I feel it can be done is for the notes to be summarized and to have a N summary at the end. So if I have oropharynx, T1 N0 is what I'm going to do. If it is T2 N0, this is what I'm going to do. If it's T3 N2, bilateral neck, single neck, is it 3D? Is it IMRT? How am I going to put the fields? So all that must be rehearsed. Only then the mind is trained and tuned to think that way. Which are the target levels? Which are the lymph node levels? How will I verify the patient? What's the treatment dose? And how will I monitor the patient? So in general, that's what happens for part 2 actually. So anyway, coming back to this, primary tumor, large T3, T4, you tend to radiate. High-grade tumors, you tend to radiate. Close up. These are very general concepts of post-operative radiation. Close or positive margins, almost always you're going to radiate this patient, even if it's a T1 N0. So if it's T1 N0 close margin, we're going to radiate. We're not going to say, oh, just because T1N0 tak payah radiation. A T1N0 tongue, although if you follow some guidelines, they will say no need to radiate. We all know that most people will jump and radiate the patients because our type of tongue cancers are a little bit different. They tend to recur very easily, whether our quality of surgery is not as good, or is it that our imaging is not as accurate, whatever the reason, we tend to recur, and hence a lot of us tend to radiate even T1. But of course, if you say no radiation in T1N0 tongue, it's correct. It's not wrong. But as you go along, and that's where experience comes in, and hopefully after a while, through our mistakes, we get a bit more experience and we become a bit more careful. Relative indications for primary radiation, deep infiltrative tumor. So that's where the depth of invasion comes in for some tumor subsites. Lymphovascular invasion, perineural invasion. Lymph nodes, any lymph node positive, definitely you're going to radiate the neck. Whether it's one side versus the other side. So that's the next question. If you're deciding to treat the neck, there are tumor subsites which are early tumors, well lateralized, which you can get away with one side of neck radiation. So all this, the summary paper has to summarize already. Buccal CA T1N0, I'm going to treat the primary tumor with the margin level 1, 2, and 3 on the same side up to how many grays? So all that has to be thought of. So if it's going to be 3D, how is my beams going to be? Is it wedge on top? Is it anterior neck on top? Is it APPA off chord below? Or is it wedge all the way? Blah, blah, blah. So that's for 3D. If you're going to do IMRT VMAT, okay, I'm going to draw the target. I'm going to give a margin around the buccal tumor. I'm going to give a PTV margin on top of that. I'm going to contour level 1A, 2, 3 with a margin of the PTV, and this is my dose. So at the end of the day, 3D is still tested quite a lot in the exams. For those of you who are learning for exam purposes, 3D has to be very well versed somehow. So I know that in some centers, head and neck 3D macam tak banyak. Most of it are done with IMRT VMAT, but please be aware for training purposes, 3D is extremely important. You need to know how to do 3D. So primary and involved nodal disease, at least 56 to 60 grays. So if it's already operated and there's nodes in that level, at least 60 grays is considered safe. There's some guidelines telling us now in the very low risk clinical neck node levels, you can get away with 56. I mean, I think that's a clinical judgment, but it's potentially doable. So you can actually do doses of different levels, dose escalating at some levels and de-escalating at some levels. But I think all that is a lot about clinical judgment. In the presence of R positive resection, site of residual disease, positive margins, extra nodal extension, you would give a boost of another 4 to 6 grays. Uninvolved nodes, you can give up to 50 grays. So this is a bit of a summary with regards to the lymph node levels. It's a bit more complex now. The addition of 6, 7, 9, 10, 11, all these things. So at the end of the day, I think knowing the main levels is extremely important. If you're doing an external ear canal, you have to be aware of cranial nerve 8, 9, not cranial, sorry, lymph node levels. If you're doing a nasal cavity, so if you're doing something rare, not very typical, please refer to the guidelines. So I think not everyone can remember, okay, nasal cavity, which one will I include? If it's a scalp lesion, you're going to have a nightmare. So just follow the guidelines and have your materials ready so that when you have a rare case, which is often, you will be able to look back and make sure you're not going too off from what is expected. So neck node levels, of course, are the 2013 Vincent Gregor Atlas kind of delineated it very well. So, so the TNM, there's also the Robbins criteria. So whatever it is, they've summarized it all very beautifully. And now we have got 12 levels instead of what we used to have before. And then it got later upgraded and it got even more minute with 4B, 4A, 5A, 5B. So I won't go into too much detail of that, but to be aware of all this. So there are several lymph node delineation guidelines, which I mentioned before. I think most of us use the Gregor guidelines. Retropharyngeal lymph nodes. So a little bit about retropharyngeal lymph nodes and how in certain tumor subsites, you need to include a retropharyngeal node as a potential target, including in NPCs, posterior pharyngeal wall, supraglottic, yes, base of tongue, yes, because it's oropharynx, tonsils, not so much, HP, what is this, I don't know, hypopharynx, sorry. So this is just an example from the exact same Vincent Gregor's guidelines with regards to selecting the target lymph node levels. So I'm just putting this to show an example of what this involves. So if, for instance, you have the selection of low-risk nodal target volumes, so P16 positive and P16 negative. So now we know that P16 positive oropharynx is a totally different disease entity. P16 negative is another disease entity, but never mind. For now, we will just talk about N0 to 1. Minimum is level 2, 3, 4, and 7A, which is retropharyngeal, for posterior pharyngeal wall tumors. So the good thing about these guidelines is that it's relatively detailed. It's not too detailed, but I think it's adequate detail, whereby for every tumor subsite, if you get this table out, you are quite safe already. Even if you think you don't want to read the whole paper, Summarizing it based on the table, you're relatively safe. So you would know that if you've got an oropharyngeal tumor, but if it is not a posterior pharyngeal wall tumor, you don't need to include 7A. But if it is a posterior pharyngeal wall tumor, you likely need to include 7A, which is retropharyngeal. Contralateral, what to do? If it's N2A to B, it's likely already 1B. So the concept is that the minimum target lymph nodes and the contiguous nodes of the affected site. So if you've got level 2 on any side of your neck, likely you have to treat 1B, which is anterior to level 2. If your level 2 is bulky, you have to go upwards to the retrosternioid, which is the contiguous lymph node level for level 2 superiorly. You likely need to go posteriorly to include level 5. You likely need to go inferiorly to include level 3. So the moment there's one lymph node positive in 2 or 3, which is the most common site of node positivity, you're likely going to treat the whole neck, which is at least 1B, 2, 3, 4, 5, most of the time. So just like that, for every subsite, for instance, this is laryngeal cancer, excluding T1 clotting. So T1 clotting is a separate disease entity of its own. But for other laryngeal cancers, you can actually follow 2, 3, 4A, 4, 6. So 6 is another special lymph node level for transglottic or subglottic tumors. So for retropharyngeal is different. Subglottic level 6, which you need to include one of those regions. If there's subglottic extension, you need to include level 6 as well. N2, N3. So you just said, I don't think anybody can memorize any of this. But if we can just understand the basic concept that, okay, for this tumor subsite, this is my minimum level. If there's tumor extension to another area, I will extend the lymph node levels. If the lymph node is positive in that one, I will include the contiguous lymph nodes and I'll make sure the low risk areas are included as well. And I think you should be quite safe. So you will notice that all these fine print below the tables are extremely useful. Just follow it. The more you do, the more you refer to this. After a while, it will be second-hand nature already. So again, hypopharyngeal carcinomas 2, 3, 4A, 7A for posterior pharyngeal wall tumors, apex. So it summarizes quite nicely. So I think for an area of a tumor subsite which is this complex, I think this is really good. The way there's some, I know some people feel, oh my God, what is this so much? But frankly, considering the complexity of the tumors, I think this is relatively well summarized. It's as good as it gets, put it that way. Any questions so far? All tired already.
Yeah. Okay, so okay.
Still okay.
Well, okay. Nasopharyngeal carcinoma. So NPC being bread and butter in oncology. Frankly, I feel the radiation is a far more exciting field than chemotherapy or any form of targeted therapy. I hope you all share that same sentiments as well. Radon is a whole different world of its own. And I think I'm a big proponent of separating clinical oncology into radon and medon, actually, by the way. Because I really think the system which is in Australia and all is actually, I don't know, I feel is way better. I don't think we can do everything. It's the complexity of how we manage patients is just tremendous nowadays. And I really don't see, I don't know how we've been doing it all these years, but to achieve perfection and quality, I really don't see how it can happen unless we separate and we subspecialize. 2 to 3 tumor sites, med-onc, rad-onc separated, then maybe there's some level of quality here. Otherwise, it's just, I don't know, to me, it's impossible. It's so crazy. But anyway, history, headache, double vision, blurring, ear symptoms. So to emphasize again what I mentioned earlier, that in nasopharyngeal carcinoma, cranial nerve involvement is extremely common. So majority of our patients don't have MRI. So when they come to us, we have to become the MRI. And from the clinical signs and symptoms, we realize that something is going on in the base of skull, something is going into the brain, and something is likely already in the orbit for a lot of our patients, right? Headache, double vision, blurring, ear symptoms, differences after chemo, paresthesia, dentition. So paresthesia is a very important sign. Numbness in the face, numbness in the forehead, numbness in the mandible, numbness in the ears, numbness in the back of the head. Neck nodes, okay, fine, that's obvious. But is it causing horniness? Is it causing jugular vein thrombosis? Is it infiltrating the skin? Is it already involving the sternocleidomastoid? Is your neck node mobile? Is your neck node fixed? That result will tell you likely muscle involved, prevertebral muscle involved, or is it infiltrative, or is it just a nice round which is moving kiri kanan? So all this will make a difference with regards to how you would treat the patient. Clinical examination, of course, eye assessment, cranial and swallowing, speech. Unfortunately, in our setting, I think our allied health support is extremely poor. We have to beg and cry to get a swallowing assessment, have to beg and cry to get a dietitian on board. Physio, don't even try unless you admit the patient. So quite often we admit patients just to get all this done. If you refer outpatient, radiotherapy sudah habis pun belum jumpa ini orang semua. So in very well established head and neck centers, right, the emphasis is a lot on the support. Support meaning rehabilitation, dentition, nutrition, swallowing, physiotherapists, social worker, nurse, head and neck nurse, head and neck therapist, head and neck what, everybody, the whole team is head and neck and all jump on the patient. And that's how you get that kind of cure rates. If we don't have all that, We just try to do the radiotherapy. We are never going to get that kind of cure rates because the contribution from all the other aspects, if you ask me, is far, far bigger than what we are trying to do to the patient, right? So if your patient's nutrition is poor, 9 hours of drawing a head and neck is not going to help the patient because the patient is likely going to die, right? Unlikely going to even survive the radiotherapy. So all these other areas are extremely important. We radiate the patient so well, but the patient can't open the mouth. They live, but they can't even drink with a straw. The mouth is all stuck. Tak boleh buka mulut sebab tak ada physio. Sudah trismus habis. All stiff and cannot even open the mouth. If we radiate the patient and we cause a swallowing dysfunction, I don't know how many people here would be happy to be alive but not able to eat. Pack for life. Not very nice to be alive if you're on a pack for life, right? There are a lot of Malaysians who live to eat actually, so not a nice place, not a nice thing to be. You can't eat. I've had patients who actually tell me, saya lagi sanggup mati daripada tak boleh makan. Saya tak mahu pakai itu NG. I'm sure you'll have had many patients who don't want to be on an NG, right? Who refuse. Die also tak mahu. So anyway, patterns of spread. So when we talk about nasopharyngeal carcinomas, just trying to highlight how complex it is and how the extension can be everywhere. Anterior, posterior, superior, lateral. So when we're looking at imaging as well, it's extremely important to look out for all these areas. So if posteriorly, whether the prevertebral muscles are involved, the jugular foramen, the hypoglossal canal. So if you see that the patient has got a cranial nerve 12 palsy, meaning when they protrude their tongue, the tongue is deviating. Even if you don't have an MRI, you already know this patient has got hypoglossal canal involvement. So even without the MRI, you know already the base of skull definitely affected. This is posterior extension of a nasopharyngeal carcinoma. So NPCs and clinical signs and symptoms are very unique, actually, very, very interesting if you look for it. You will see most of the time something or other. I don't think there are any in NPC patients where have no signs. At least they have got a ear block or a ear nose or a ear block or a ear discharge or something like that. So anyway, clival with prepontine space. So prepontine space is the space posterior to the clivus, anterior to the base brainstem, which is very often missed in contouring because we're trying to conserve the brainstem and we didn't realize that the clivus is involved. We underdose the clivus and the patient recurs in the clivus. Lateral parapharyngeal involvement, infratemporal fossa. So when you've got V3 involvement, foramen ovale. So if your base of skull got massive tumor sitting there, likely your V3 is out, likely your V5 is out, likely your cavernous sinus nerves are out, and likely your cranial jugular nerves are also out. It's just whether you look for it. Especially all those massive tumors, the infiltrative ones in the whole base of skull. So sometimes it infiltrates, sometimes it encases the nerve, but it doesn't infiltrate the nerve. So then your function might be somewhat present, but you know that eventually these are the patients who are going to lose their cranial nerve function. So cranial nerve reversibility of palsies is not excellent. So some patients will have some improvement, but if it is already involving the nerve function is gone. You may cure the tumor, but reversing neurology, not always. Some patients will have permanent facial asymmetry, permanent facial paresthesia, permanent blindness, permanent diplopia. They might be cured, ABB DNA might be negative, but the reversibility of the nerve function is very subjective. Most of them may not reverse. So tumor invasion into anatomical site. So if we saw for non-NPCs is more of a margin-based voluming for the CTV, it does not apply to NPCs somehow. So for NPCs, these are tumors where there are agents with almost 60% involvement of other structures. So when we talk about the 13 or was it 14 structures that must be included even in a T1 NPC, anyone, so that we all don't fall asleep. What are those structures that must be included in nasopharyngeal carcinoma? In the CTV?
The posterior 1/3 of the choana, the nose.
Nasal cavity 1/3 some more.
The
Maxilla 1/3 some more. Parapharyngeal space some more. Retropharyngeal space some more.
the posterior 1/3 sphenoid.
Clivus.
Clivus, at least if a T3 tumor, at least half of clivus must get in. T4 tumors, whole clivus must get in. T3 tumors, cavernous sinus must get in. T4 tumors, of course, must get in, at least on the same side of areas. So basically, all these areas are considered high risk. The prestyloid, the prevertebral muscles, parapharyngeal space, pterygoid process, sphenoid bone, clivus, prevertebral muscles, foramens, base of skull, hypotenuse, they've spelled out every single part lah. But it's just showing us percentages of involvement of disease microscopically. And this is a table just to highlight how there are differences in the guidelines. So the RTOG group versus the Hong Kong group, the China group, the IRO group. So there's some differences, but in general, I believe most people are following what the Hong Kong, Singaporean, China group follows because our type of NPC is more like what they see. So NPCs, you've got the type 1, the type 2, and type 3s, right? So the type, which type is most associated with EBV DNA? ABV.
Type 3.
Type 3, right? So it's the type 3s which are associated with EBV infections, right? So why some people, the same virus, why some people get infected and others don't, nobody knows. I think we will know in the future, but for now we don't really know. Whether it's a cultural issue, genetical, dietary, lifestyle, combination, don't know. So even in Malaysia, among Malaysians, a certain ethnic group has got a higher likelihood of NPCs, more common in the Sabahan, Sarawakians, Chinese, Malays, after that, Indians, very rare for some reason. Somehow the Indians don't really get NPC for whatever reason, don't know. So it's genetical, whether it's environmental, lifestyle, whatever. So at the end of the day, certain things remain the same. GTV primary is GTV primary. So if you've had chemo prior to that, it is still the residual GTV. You've got a margin that comes around it. So of course, GTV plus 3 mm. So there's some people advocating GTV plus 5 mm, some advocating GTV plus 5 mm plus 10. You will also see the high-risk target volume. Some are including 5 mm, some are including 3 mm, some are including 10 mm, some are including 5 to 10 mm. So I'm just trying to say that depending on the guideline that you use. But I think at the end of the day, in all practicality, for most of us, it is a clinical judgment and what we have learned to adapt. Because frankly, none of our patients follow these guidelines setting in our setting. So with the waiting timelines and also the neoadjuvant chemo that has come in, some these trials did not include neoadjuvant chemo. Some of the trials included adjuvant chemo. Some of the trials used concurrent chemo. Some of the trials didn't. Some of the trials no pre-op chemo. No neoadjuvant, everything radical RT. So in that kind of uncertainty which exists, I really don't know. So I was talking about the consensus for target delineation for neoadjuvant patients. So patients who already had neoadjuvant chemo, can we de-escalate the dose? Can we escalate the dose or must we keep it the same? I think it's still an area that we don't have answers to. So hopefully once Professor Melvin's paper comes out, we'll have a bit more answers. I don't know whether we'll have a bit more answers or we'll have a bit more confusion after that also. But that's how oncology is. At the end of the day, a lot of things are actually relatively uncertain, and that's why a certain level of experience in the field is needed to come up with some kind of safe clinical judgment. We've all gone through that phase of, even now, making mistakes and learning from our mistakes. And that is the natural process of learning. So that learning will continue till the day we stop practicing oncology if it's oncology. But the whole process of learning will continue till the day we die in whatever field that we do, even in the whole life experience of existing. So I truly believe that. So if we feel that, oh, learning is done the day we finish exam, that is the start of problems. Major problems. Because in oncology or even any field in that matter, whether you're a doctor, you're a lawyer, you're an engineer, I think that's only the start of learning, and that learning will never ever end. So as long as we are open to that idea that we will continue to learn, we are happy, we are safe. We decide that we will not learn anymore and we shall shut down, we are going to have major problems. So anyway, so to highlight again the differences, posterior nasal cavity, 1/3, 1/3, 1/4, 1/4, 1/3, 5 mm of the cornea, 1/3 to 1/4. Cavernous sinus not stated. Here T3, T4 include, T3, T4 include. So I think in general, from my observation, the way Ann Lee does it, the Hong Kong group, China, Singapore, I think that's what most of us are kind of doing. So we're trying to draw a bit bigger. The more Western guidelines are more of NPCs, which are not WHO type 3. They are usually keratinizing variants, which is more common in the Western world. So I don't know whether when these guidelines are based on those type of patients, whether it is actually can be applied in our subset of patients who are mostly EBV related, more T3, T4s. Frankly, our tumors which are T3, T4 are far more than the Western world. To start off with itself, NPCs are not as common in the Western world. And even among those patients that they see, our proportion of T3, T4s are far more. We are mostly type 3, we are mostly EBV related, we are mostly late presentation, we are mostly late treatment, we are mostly late everything. So at the end of the day, a clinical judgment is needed. But if you want an answer for exams, you can follow one of these guidelines which tell you in general, sphenoid, clivus, posterior half of nasal cavity, maxilla, cavernous sinus, ethmoid, posterior ethmoid has to get in, all this blah, blah, blah. Retropharyngeal lymph nodes, retropharyngeal level 2, 3, 4, 5, all has to get in 1B. A little bit more on the low dose clinical volume. So level 4 and 5B. So some include it, most of it included. There's some differences. The gist of the story is that in NPCs, level 1B, 2, 3, 4, 5 all comes in. If you have got a very well lateralized T, not lateral, very well confined T1 and 0, maybe 1B you can omit. In all other circumstances, 1B definitely gets in. 1B gross nodes, 1A has to come in. NPC with gross nasal cavity involvement and 1A has to come in because of the nasal cavity and 1A being a target. So it follows that same concept of how you decide on your target organs and the target leaflet levels. NPC delineation and doses. So most of us are using the 35 fractionation. There are some centers and some physicians who use 33. It doesn't matter. So if you do 70-33, you need to do 59.433. And you have to follow the OAR constraints for 33 fractions. The OAR constraints may not be the same for 33 versus 35 because 35 is 2 gray per fraction and 33 is 2.12 gray per fraction. So in radiobiology, you will know that it's different, right? Radiobiologically, the dose per fraction when it changes. So it's just like saying when you do SBRT, 6 gray single fraction or 7 grays in 2 fractions is not the same as 7 times 2, 14. So 14 in 2. It's not the same, right? It's different. The dose per fraction will change the whole radiobiology, right? So having said that, if you're doing 70 in 33, it's 59.4 in 33 and 54 for the low risk CTV. If you're doing 70 in 35, which what most of us do, so it's 70 in 35 gross disease primary nodes. Next dose level is 63.35. If you are very happy to do a low dose, low risk CTV, it's 56.35, which I don't do because I don't know how safe it is. But you can do if you want to. I don't because I feel by skimping on this dose, I don't think I'm minimizing toxicity that much. Although it's good, I mean, it's nice, but I am not that brave to take the risk, so I don't. But if I had good MRI, good PET scan, treatment starting ASAP, my patient doesn't wait, everything is as per textbook, happy to do it. But I think where I work, very few things are as per textbook, so I don't think I want to follow. But it's up to you all, but you can. Plan evaluation. So how do we evaluate plans in general? We talk about dose homogeneity, meaning the high dose region, low dose region. How is the fall off? Is it conforming very well? Maybe later I'll show 1 or 2 plans, but dose conformity with regards to how well the dose conforms around the area of the tumor, whether there are hotspots within the PTV or outside, entrance and exit doses. So I know a lot of candidates, when I say, okay, evaluate the plan, they'll straight jump to 95%. And that's all they want to see, which I think shouldn't be. You should start, I tend to start with the high dose region purely because when you start with high dose, you will see the areas which are hot and the areas which are hot towards cold. So you start with say 105%, 103%, 100%. So then you know, okay, this is mostly hot in this region. It's quite well conformed. It's homogeneous. The hot area is everywhere, not only in one place. And this is the hot area in the OARs. Because if you put 95, you will see everything lighting up nicely, chanted like that, but you won't see where are the regions which are hot, which I believe is a bit of a problem, especially if your 103 is in the area which you don't want it to be 103. 103 in the lung will be a disaster. 103 in the brachial plexus will be a disaster. 103 in any other area which is important will be a disaster. So dose conformity, hotspots, entrance and exit dose. So after 103, 100, maybe 98. So if you're doing head and neck radiation, you want to look at D98, you want to look at D1cc, okay, fine. D95, great. 95% dose coverage, great. And then you want to look at maybe 70, 60. So I usually see 35, I see 40 and I see 45 because 45 grays is my cutoff for my midline structures, oral cavity, larynx. So if these structures have less than 45, I know that toxicity is going to be tolerable if I can. So sometimes it's midline tumors is a bit difficult, but in general, most tumors when you contour within 2 centimeters or 1.5 centimeters from GTV, your 45 grays should be able to fall off. So you can actually push the system and tell the physicist, ini boleh kurang, boleh turun, because if your midline dose is low outside the PTV, tolerability will be better. Hopefully your patient will not gag, will not choke, will not have severe mucositis, will not go back for home leave on Friday on the 5th week and not come back for the 6th week. So a lot of patients' commitment is not as great. Painful, sakit, tak mau lah doktor, tak boleh makan, tak payah lah doktor, susah lah, tak mau lah. So we have, our majority of patients are in that kind of a mode. They're not the happy, jumping kind of patients. Their socioeconomic background is terrible. They don't get to earn if they're doing radiotherapy. So for a lot of them, their family has no food. And I don't think they prioritize their health over their children's welfare. So a lot of our patients will just default if it's difficult, or suddenly they realize they're coming as outpatient for RT and towards the last week, they can't drive their Grab anymore. They would rather drive their Grab than finish their RT. Right? If your next meal is a concern, I'm sure you would do that. Entrance and exit doses to make sure that the dose exiting to the parotids, if at all, other structures are within tolerance. OAR doses as we looked at one by one. And of course, the DVH at the end of the day. So this is a summary of our volume evaluation form. So of course, the physicists have all got this template. So they would have already looked at every single thing. But when we evaluate the plan, we need to make sure as well. So you notice that some are Dmax based and some are, of course, volume based. So have to know how to evaluate these things. What does V50, 30 mean? What does V30, 50 mean? Among your PTVs, whether you're achieving D98, D1cc. So D2cc. So I mean, of course, if you go by guidelines, these are the things to look at. Whether you optimize your GTV to 100% versus you optimize your GTV to 95% makes a difference as well with regards to the final evaluation. If you tell your physicist GTV 70% optimized to 100%, obviously you will achieve your D98. Your D2CC might be the other problem, but anyway, you will definitely achieve the D98. So when we look at clinical trials involving radiation, right, the variability is so much because the radiotherapy plan depends on so many things. Where's your normalization point? Who did your optimization? What kind of algorithm was used in the optimization? What were your constraints? Where was your Dmax? Where was your normalization point? What was all those factors? So at the end of the day, when you see a radiation plan, you might thinking, okay, they say this is the tolerance, this is the cure rates, but I don't know whether my patient will get that exact same cure rates because I still feel it's dependent on a lot of things. So yes, we follow the guidelines, but to be careful of the local setting is what I'm trying to say here. So what you are actually doing and what is your setup. Toxicities, of course, we know head and neck is among the most toxic radiation sites to be done. If your patient doesn't die, congratulations to you and the patient. I'm sure all of you all have seen patients on radical radiation to the head and neck who actually die. So what is one of the main signs or reasons to die, or early signs that eventually might die? Anyone?
Aspiration pneumonia.
Aspiration, but while the patient is on radiotherapy, just eating, swallowing, assessment. Of course, aspiration is the most common cause that they die. But what are early signs to say that, okay, this is already a problem? Better be careful. Anyone? Weight loss.
Weight loss.
Which there is a clear translation to survival, right? How many % weight loss translate to how many % reduction in survival? Anyone? These are all like landmark trials, kan? Head and neck, berapa persen berat jatuh, berapa persen mati. The survival, it's death. It's not progression or recurrence. It's death. Die. So you're going to look it up. Okay, anyway. So if your patient starts to lose weight, it's already like bells ringing. Something's going to go wrong. Something's going to go wrong with this patient. Better jump and admit the patient and give the nutrition or do major measures. So you have to be very careful. There are many established head and neck centers overseas whereby no NG, no PEG, no radiotherapy. Go home. They're not going to accept any kind of alasan. Saya boleh minum, tak apalah doktor, saya boleh itu ini all. Nothing doing. No NG, no radiotherapy, bye-bye. There are some centers which go to that extremes because they know it is impossible to salvage a patient if they're going to go downhill because of nutrition. So these are all very important things. So of course, we can't force our patients. They all say, tak mau lah, tak payah lah, doctor. So we of course try to balance it a little bit, but weight loss is extremely significant. The biggest benefit or the biggest game changer in the whole radiation, if you ask me, is nutrition. It's a bit like upper GI. If your patient's nutrition is poor, you ayam mati ka, you BMAT ka, you tomo ka, you apa benda ka, there's no meaning to it at all. So for majority of patients who cannot afford the milk, trust me, none of us can afford the milk also, I think. If you were to drink 6 times a day, 6 scoops of milk, for instance, you're on full NG, how much would you spend on milk over 7 weeks of radiotherapy? Anyone?
About 3K.
Huh? About what?
3,000 plus. I think.
Yes, it's almost 3,000 plus just for susu. If you're on full feeding. So majority of patients, even if they need milk like 4 times a day, if they're buying on their own, what is the most common thing that they do?
Reduce the scope.
Yeah, they dilute the scoops. They start diluting the milk, or they start reducing the scoops, or they don't drink. They just take once or twice. So the best thing you can do for your patient who are majority poor, right, in KKM setting, how to pay $3,000 for susu, suruh $100 come to HKL pun tak boleh. So at the end of the day, all these patients must be under welfare. Magna will provide them 3 months of susu sent to the house. So that would be likely the best thing you're going to do for that patient. The susu is extremely, but nutrition must be assessed following speech. So sometimes we can't get the susu sorted on time, or patient also tak pandai, doesn't give the document, blah, blah, blah. We admit them just for free susu. Don't care, just stay in the ward and get the susu done. No choice. So swallowing dysfunction, speech, cosmosis, airway, fertility, well-being, everything is a problem in head and neck cancer. Look bad, feel bad, can't talk, can't swallow. Any questions?
Oh,
So this is the last, sorry? Any questions? Any comments? Anybody want to share anything before I just show a little bit? We'll stop at sharp 6:30. I know the Malays have to book out also.
Hi, Dr. Vice, there's a question in the chat box, I think from Jeffrey. His question is, if the NPCs, if for example the level 2 is not having any extra nodal extension, would your 5 mm expansion for your CTV node 70 extend into the SCM? Would
So
you
not
share?
all positive with no SE. So the GTV 70 is the gross node,
Hmm.
and the CTV 70 will be just margin. I don't know where it falls. But if the node is gross and it involves the muzzle, then the CTV has to include the area of the muzzle as well. But if it's not involved and you just give a 5mm margin, it doesn't matter where it falls, it's just the 5mm margin around it. So the GTV node is gross, and then you've got a CTV margin around it, and then the PTV, and then your whole lymph node level. But if the node has extracapsular extension or the primary tumor is invading muzzle, and your muzzle is matted or involved, the concept is that the high-risk CTV must include the muzzle as well. If you go strictly by principle, whole muzzle from origin to insertion gets into the high-risk CTV. Because when you have tumors involving muzzles, microscopic sterility cannot be achieved most of the time with pure chemotherapy. You need radiation.
Any more questions?
So if we have any questions, just feel free to shout out. If I can just show a little bit with regards to some of the atlases, because I think some of you all, I don't know whether quite new or I don't know whether you all know, but just to show a little bit, where is it? Give me 1 minute. A little bit about some of the online atlases that are available, which are really quite useful, frankly. I think for those of you who are not used to it or have never used, I think it's some things that you all might want to consider exploring, because I think there's now so many different types. I only know one or two, but I know for many people, they have all actually, I know the younger generation are very good in all this. So please find out, work in a group, talk to others, find out what you can do to facilitate. Because frankly, oncology is a lot to learn, is a lot, like a lot. But if you work in teams, I really believe if you work as a group, it is far easier rather than doing it on your own. So this is just one example. So can you all see? Can you all see? Sorry.
Can see.
Yes, can see.
So this is one simple example which shows you slice by slice. So if you open this in your contouring, or you just open it in your phone, or open it if you work in a center which has screens side by side, excellent. HKL, do we have side by side? I guess. I don't know. I never tried it.
Yeah, but no internet connection at the side.
No internet, internet. So anyway, so last time we used to use the Apple computer, but only one fellow can use, others cannot. So anyway, yeah, so within the limitations that you work in, so if you actually draw with this side by side, it's excellent because it will show you exactly based on every lymph node level. I think this is a really good way to start off target volume, neck node delineation. So you can see exactly. So you can actually draw on this side and look at this side and just compare. And then when you look at the actual atlas, if you're really unsure, I think this is so much easier than trying to memorize the atlas. There's no one who can memorize it. Okay, maybe some people have very good memory, I don't know, but I definitely cannot memorize the atlas. So I used to use this a bit, but before that, we went through the painful process of trying to learn it on our own. Then when I realized things, I was like, oh my God, why were we suffering so much? I don't know. So anyway, some of us were trained in the era of 2D. So when I trained, I was trained in 2D. We learned 3D maybe towards the end, because the bulk of cases that we did were, during my time of training, 70% 2D, 30% 3D. Then towards the end of training, maybe 50% 2D, 30% 3D, 10% IMRT VMAT. So most of us learned IMRT VMAT after we graduated. HKL started doing IMRT in 2010, the first center in the country to start IMRT VMAT. IMRT at that time, VMAT later. So when some of us finished in 2012, we were all groping in the dark, basically. And after a while, we kind of, okay, get used to it, learn it. So a lot of it, we actually just learned it on our own and pandai. So anyway, yeah. So this kind of contouring atlases, I think, are really, really useful. For those of you who have never seen, please try to get into some of these portals, because they're all free. Very, very useful. Makes life a lot easier. Contouring can be a lot more of a pleasant experience. Lastly, last 5 minutes, just an example. Where was I? So this is an NPC that we did the other day, but just to show some of you all. Oh shit, sorry, this is NPC audience. So I think the gist of the story is that have to practice a lot, like really a lot. Like if not, cannot. This training does not happen. So it's like how surgeons spend hours in OT. For us, it's hours of drawing, like OT. I always equate radiation oncology like surgery. You need to select your patients properly. You need to talk to your patient properly before the surgery. You need to take proper consent from the surgery. You need to assess the patient's socioeconomic background properly before the surgery. You need to make sure your patient is up for it, motivated, will go. You need to assess the family structure that everybody will support this patient. You need to take the patient into OT. You need to know what to do during the OT. You need to pre-plan your operation. You need to carry out your operation. So the thing about surgeons is that the operation is one-off. You need to finish everything before the GA and come out. Ours good thing is we can break it up, do morning, do afternoon, do tomorrow, do weekend, but you have to get it done at the end of the day. But your patient must survive the surgery. Just like that, the patient must survive the radiation, and the patient must not have, hopefully, bad complications from the surgery. And hopefully the patient's ECOG or performance status is the same or better as prior to surgery. Only then this is a successful surgery, and the surgery leads to cure. Otherwise, the surgery is a failure. Same exact concept with regards to radiation. You need to select your patient properly. You need to talk to the patient properly. You need to examine the patient properly. You need to take consent. You need to assess socioeconomic background. You need to make sure simulation is planned. Simulation is done properly. Drawing is done properly. Everything we can do it slowly. We don't have to stand in the OT for 12 hours or 15 hours. We might draw for 9 hours. At least we can sit down. Surgery, you can't sit down. Or some you can, but most of you can't. And you need to finish the surgery, radiation, make sure the toxicity is not terrible, make sure the patient doesn't die, make sure the patient survives, make sure the patient is cured, and make sure the long-term sequelae is not terrible, that the patient regrets surviving the disease. Okay, so this is a little bit of an NPC patient. So trying to show a tumor here, going right up into the ethmoid. This is a case that we just did a few days ago, so I thought, okay, I'll show a bit. Ethmoid involvement, coming right down into the sphenoids, going into the perigo-maxillary fissure, coming down into the lateral cranial fossa, maxilla involved as well. There's some erosion into the maxilla, coming down into the posterior pharyngeal space, prevertebral space, no pleat, coming right down, some retropharyngeal lymph nodes over here, large nodes, coming down here, bilateral neck nodes. So of course, huge neck nodes as well. So just to show and this is a very typical bread and butter NPC that I think all of you all will see every week. All this going into the nasal cavity, going into the sinuses, going everywhere. So even in the absence of MR, we can't MR everyone, unfortunately, although we would love to. We are still getting referrals from 11 hospitals, so we can't MRI every patient who comes from 11 hospitals. So we highly select young patients, sometimes I push. Older ones, tamau. See lah, what to do. Any questions? So this is the voluming. We've got the PTV, CTV, GTV, just to give some flavor. I mean, we can't teach this in one day, but just to give some idea of what we did for this patient, just to give. So this is the neck node levels, going right up, going all the way. This is no MRI, so the contouring is bigger, memang bigger. But to include the parapharyngeal spaces, to include the maxilla, to include the ethmoids going right up into the sphenoids, all the way to the top. So in NPCs, right, when you look at coronal and sagittal, right, you must see something like this, going right up into the base of skull. If you're not hitting the base of skull, likely you are not reaching enough. So even the sphenoids, you can only get away with treating half the sphenoids if it's a pure, confirm 100% T1 and 0. Anything more than that, the whole sphenoid must get in somehow into the high-risk CTV. The clivus has to get in as well. So this is the clivus over here, C1 over here. So this is likely a very typical NPC plan. The nasal cavity, especially got a nasal cavity involvement, so it has going even more in front. So of course, this is more than usual. So it has to be tailored to the extent of that particular tumor. But the guideline just now we saw with the minimal target, right? That's minimum, and then you add on from there. It doesn't become less than that. So this is level 1A, and then 1B, 2, 3, 4, all coming right to the bottom. I mean, we can't go through every single type of patient, but just to show in general. So the volumes, bigger cranial fossa. So cavernous sinus, for those of you who don't know where it is, this region here. So in the high-risk CTV, T3, T4 tumors, the cavernous sinus has to get in. This patient has got gross disease going into the maxilla, likely foramen lacerum as well, because we don't have MR, but we included it as well. So at the end of the day, I know this whole area of the base of skull, cavernous sinus, lateral cranial fossa, ethmoid sinus. So if a sinus is involved, like the maxillary sinus, even if it's just the medial wall, the concept is that the whole maxilla has to get into the high-risk CTV. So just like that, the ethmoids are connected. The posterior ethmoid, there's 3 parts of ethmoids, the anterior, medial, and posterior. They are all connected to each other. So once sinuses are involved, right, you're likely going to include bilateral areas of the sinuses. So to have some idea where it goes. So of course, you will notice 70 grays is hitting the orbit, hitting the tracks, but that's fine. When we plan it later, we will still respect the OAR. So that's why the baseline eye assessment is important. If your patient is already blind, there's nothing much to lose. If your patient is not blind, you might want to save the eye at some cost. Hence, you might need to underdose or undervolume that area, but not the other areas. So the other areas will still push on. And at the end of the day, yes, it's overlapping with the brainstem. It's very close to the chiasm. So the clinical judgment has to be made about how high you want to push or how much you want to compromise. There's no right or wrong about it. It's a clinical judgment again. So in the era of IMRT VMAT, the area with most common for recurrences post IMRT VMAT is actually the parotid nodes. So in NPCs, parotid nodes are common. So at the cost of trying to save the parotids for improvement in xerostomia, I think nowadays it has been known as a well-established entity of parotid recurrence post IMRT. In the era of 3D and 2D, the most common area with relapse was anyone?
Clivus,
Clivus. Why?
because we spare after phase 2.
Yes, in phase 1, we are giving 40 grays and then we start shielding. So we shield until the clivus is underdosed. So in the era prior to this, when we give phase 1, phase 2, right? So phase 2 shielding. I don't know to what extent NPC 3D is being asked in the exams nowadays, but I believe it has to be known. I don't know, I've not found out about that, but 3D must know. A lot of centers are still doing a lot of 3D. Of course, like HKL and all, I think 100% head and neck is IMRT VMAT. I think very few lah. Maybe 5% not for some other reason. Usually S-type sudah habis. That's maybe the most common reason. Otherwise, it's almost all lah. 3D, IMRT VMAT. VMAT actually, we don't even allow IMRT because the treatment time is too long. Our machines are old, they break down all the time. There's a long waiting list. I think in terms of resource limitations, we are the champions and hence we adapt. Any questions?
Otherwise, there's a question in the chat box from Kei. So the question is, when do we decide on resim? Do we resim even when the bony landmarks are still matching? And is there a time limit for treatment delay?
Oh, time limit for treatment delay is no delay.
Hmm.
So if today means today must treat by right? Because we
Yep.
know in head and neck, the overall treatment time that we don't want to exceed is how many weeks? Anyone?
Exactly.
7 weeks.
Is it 7 weeks?
7 weeks. Mm.
So ideally, you don't want any gap.
Hmm.
You don't want to exceed the overall treatment duration. So you need to balance it with how fast you can receive, how fast you can replan, how fast you can redo. I think the fastest we have received, replan, and approve is 1 day. Kan, Ananda?
Yes, otherwise?
We have done in 1 day also, right?
Yes. Oh,
Yeah.
most of it, yes. Same in the
Actually, we
morning.
receive a lot because our waiting time is significant, kan?
Hmm.
So some of us can do in 1 day, provided our disease doesn't do anything else but our plan. Don't do anything else, just do what ini saja. So what we do is, if we really need to resim, so it has to be weighed with the benefit on the verification, how much it has run off. Frankly, in all practicality, I've had patients where lari, but the bony landmarks are matching. It's a soft tissue which lari in the air. It's not right, but no choice, because if I resim the patient, he will lose his slot maybe, or he might get to do, or it's a long weekend, or I've done my plan, but diseases can't finish the plan, whatever reason. So if it's going to harm the patient with regards to doses at the cord, of course you can have to resim, you cannot get away with that. Dose at the tumor site, you're going to underdose or you're going to overdose the patient, then you definitely have to resim. Even by selecting patients, we resim quite a lot, unfortunately. Two good response also resim. No response also resim. Right, patient progressing on an RT also resim. But at the end of the day, it's a clinical judgment. So I think our threshold is somewhere in between. Ideally, you will resim. So if you have only 3 patients for RT in the whole week, you resim everybody lah. So at the end of the day, I think the clinical, you must not harm the patient for any reason. So a little bit of dose on the skin, I sometimes close an eye because I just feel the system cannot cope with this kind of perfection. Of course, if I work in a center where resources are in abundance, happy to do all that, but we don't work in that. Any other questions? 6:30. Any other questions? No.
So far tak ada, Dr. Wai.
Okay, great. Let's go after puasa. Sorry to the Muslims. I know we had to take up your time, but we couldn't find other weeks as well. So anyway.
Thank you, Dr. Wai, for the very informative and very encouraging talk today. Though it
Encouraging.
we
I like
didn't
that
cover,
one.
yes, we didn't cover most of the topic, but yes, time limit is a concern. If you guys can see in the screen, there's a QR. Please scan for your attendance. And if there are more, any other burning questions, please leave in the chat box. We will try to see if we can address them later. There will be a recording of this session that later we will upload into a drive and we will share the link to everyone. Thank you, everyone.
So last words, I think if I can, I think the whole idea of us doing this is very selfish actually. We want our patients to be treated properly, hopefully, and that's the reason we do it. So we want patients to benefit. I think that's the ultimate aim here. So hopefully everyone who joined would have, all of us would have learned something, I'm sure. And I hope that it will pave the way towards improving our knowledge and skill because being in this field, if we equip ourselves and we know, we do our best in doing our best, the benefit is for our patients. And that's the ultimate aim here. We want our patients to benefit through us. And that's what we are all trying to do. So anyway, thanks everyone and selamat berbuka.
Thank you, Dr. Wai.
Thank you, Dr. Wai.
Thank you.
Thank you, Dr. Wai.
Thanks, Dr. Rai.
Thank you, Dr. Bai.